Alright, so let's continue looking at the cardiovascular system. Specifically, I want to look at the cardiac function for this installment. Alright, so cardiac function, of course, refers to the heart and the way it works. I like to think of this system as being fairly simplistic. It's just a little more than a pump with some tubes, and it's important, but at the end of the day, that's pretty much all the heart's doing. It's just pumping liquid throughout the body, blood. Um, and anyway, so let's go through and we'll look at this. Um, and this might be overly simplistic, some of these things, but we'll get into some of the mechanics that are more in depth. But starting off, first off, we have the heart here. Okay, so this model here shows the electrical system of the heart. But before we get into that, I just want to review for everybody how the flow of blood works. Okay, so here we have the heart. Let me change to. Okay, so we have, this is the right atria. Okay, this is the right. Maybe yellow is not the right. Let's try blue. Blue's better. Right atria. We have the right ventricle. Okay, left atria and left ventricle. Okay, so those are our four chambers of the heart. We have, of course, a four-chambered heart, and the way that blood comes in, it's going to come in through the vena cava. Okay, so it comes back. So it's coming back deoxygenated. Okay, so this is that kind of more dark blood. I've had the question before. So maybe there's a few of you out there who have the same thought, and if not, well, I'm just going to say it anyway. I've had people ask me, is deoxygenated blood blue? Of course, because your veins appear to have a blue coloration. So some people have it in their mind that blood that has low oxygen content is blue, and it's not. Blue, you don't have blue blood unless you're an alien or something. The blood that's deoxygenated has a less bright color. It's darker in nature. If you ever see somebody bleeding and it's really like very, very dark red, almost black looking, that means it's deoxygenated, so the bleed is coming from a vein. Whereas if blood's coming from the other side, if it's coming blood that's already been oxygenated from the lungs, it has a very, very bright coloration to it. So on the flip side, if you ever see somebody bleeding and it's really bright red, it means it's coming from an artery, and it's probably a lot more problematic. Okay, so anyway, we have our blood. It comes in from the from the vena cava. Okay, so it comes back from the body, goes into the right atria. The right atria then will pump blood down to the right ventricle. This ventricle is going to pump blood out, and it's going to go out. The tube's not really here, but it's going to go to the lungs. Okay. Then it's going to come back to the left atria from the lungs. Okay. Maybe that's a better way to do this. Okay. So it's going to come back to the right atria from the lungs. Right atria. Oh, sorry, left atria. Left atria squirts down to left ventricle, and left ventricle squirts the blood out through the aorta, and it's not shown here, but it's going to go out. This is not anatomically correct, but essentially it's going to go out to the body. Okay, it's going to go to the body via the aorta. Okay, so that's the flow of things: into the right atria, down to the right ventricle, out to the lungs, back to the left atria, down to the left ventricle. Left ventricle pumps out to the aorta, and then it goes out to the body from there. Okay, so that's how the heart works as far as its pumping functions. Now, if we look at the electrical of the heart, impulses to control the heart rate come from, well, upstream. You have the brain. The brain stem's actually controlling that, but the first node, if you will, on the heart is the SA node. Okay, so it starts here. Impulse travels to the AV node. Okay, and as it's traveling down, it's spreading across. And we'll talk about this a bit more, but it's spreading across this way. Okay, so if you ever hear a heartbeat, what you hear is boom, 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 boom. That first smaller boom, if you will, is the atria. Okay, the atria are contracting at the same time. Okay, so boom, boom, boom. That's the first bit of that is the atria contracting. And then as the signal comes down, it branches out this way and this way, and then it spreads around like this. Okay, so it goes down to the AV bundle, then eventually it comes down to Purkinje fibers, and then it spreads around. Um, so and as the signal's coming out, it's also doing the same thing. It's all propagating um, kind of at the same time. Okay, at least ideally, in a healthy heart, this is what happens. Um, both both sides of the atria, the left and the right atria, contract at the same time. When they contract, they send blood down, and then that blood gets shot out to where it needs to go, either the lungs or the body, as the two ventricles contract at the same time. So there you are. Boom, boom. The bigger bump sound is the ventricles. The ventricles are bigger in nature. They're more muscular, so they're more pronounced when you're hearing it, when you're seeing the electrical activity. That's why. All right. So we'll move on. We're going to talk a bit more about that moving forward. But first off, a quick review of the anatomy here. So you of course have, this is just talking about the heart muscle. All right, so you have the heart muscle here, the myocardium. Okay, so those terms once again: myo referring to muscle, cardium referring to the heart. Okay, endocardium, that's the kind of the I don't know, the inner epithelial layer of the heart. Okay, you have the pericardial sac and cavity here. All right, and you have coronary arteries, which supply blood to the muscle walls. It's kind of a weird thing, all the heart does is pump blood around the body, but it doesn't supply itself directly through the walls. It has to, be supplied from the outside. So that's the coronary vessels, both arteries and veins. Okay, so just a quick look at that. I don't really spend much time on it. That's an anatomy deal. All right, so let's look at the cardiac cycle in a bit more depth. All right, so first off, if you see this, you probably looking at this crazy graph right here. This guy. This graph, if I had to tell you, like, this is the most central thing that you need to know about how the heart functions. If there was one slide, this would be that slide. Okay. The reason I say that is because if you understand what's happening at the various stages of what's going on here, and I'm going to go over it, but if you understand what's happening here, you have a fairly good grasp of how the heart works, and to a certain degree the entirety of the cardiovascular system. So definitely know this. Okay, it's exceptionally important. So before we get into this too much, terms you've probably seen before. There's systole, diastole. If you've ever had a blood pressure taken or you've done it yourself, they'll say, what's your systolic or diastolic pressure? Systole refers to the phase of the cardiac cycle in which the heart is contracting. Okay, so when the ventricles or atria are contracting, it's systole. During relaxation, that's referred to as diastole. So diastole is relaxation, systole is contraction. All right. So let's look a little bit. At this graph. Okay. So it's actually a really, really cool graphic, and I want you to focus. Not that the middle part isn't important, but focus on the bottom part here and the top part. Okay. That's what I mostly want you to see. All right. So the cool thing about this is what this graph does is it overlays a lot of different things happening at the same time. Okay, first off, your first layer here, the ECG, refers to electrical signals occurring around the heart. Okay, so that's the first layer, and you've probably seen this before. This is normal sinus rhythm. Okay, you got your PQRS T waves happening here. All right. Down here we have, this is showing all the different valve openings. We have blood pressure, we have pressures happening. There's a lot going on here. I don't really focus too much on it. All right. But then you have the bottom here, and then this is just strictly the volume of the left ventricle in milliliters during the different phases of contraction. All right. Systole versus diastole, relaxation period, contraction period. All right. And there's some subdivisions within that. There's isovolumic relaxation, there's ventricular filling, there's isovolumic contraction, and then there's ventricular ejection. That's the part where the blood's, of course, leaving. Okay, so let's look at this. So first off, we have our P wave. Earlier, I was playing human beatbox and doing the whole ba-boom, ba-boom, ba-boom thing. The first boom sound is that atrial contraction. That's the P wave. That's where you're having the signal going from the SA to the AV node. That's where you have your contraction of the atria, and it makes a smaller, in magnitude, a smaller increase in ECG activity here. Okay. And then the second bump, then the bump, is the QRS complex. Okay, and that is ventricular contraction, right? And you'll notice that the magnitude of change of electrical activity here is much higher, and that's simply because there's more size to that musculature. Okay, so bigger muscles require more electrical activity to contract them, so you have more magnitude there. All right. Now, what's shielded within this complex, okay, where it goes down, then up, then down, and back up to rest, what's shielded within that is repolarization of the atria. All right. And as we know from neuromuscular, the neuromuscular unit, what we know is that whenever a muscle contracts, it also has to repolarize, right? Go back to, resting membrane potential, right? Resting membrane potential hits threshold, you have a spike in membrane potential, it goes positive, then it comes back down, and then comes back to rest. Sometimes it hyper repolarizes or goes, lower than resting, and then it goes back up. Anyway, so when the atria contract, they contract, and then they have to relax or repolarize, and that repolarization also has an electrical signal, but it's such a small amount, considering that the contraction was only this much. It's such a small amount that you really can't see it within this complex. Okay, but within this complex, you're having atria repolarization as well. So it's not wholly correct to just say the QRS complex is ventricular contraction alone. It's got a little bit more going on. Okay, but in a reductive sense, your P wave is atrial contraction, your QRS complex is ventricular contraction, and then the T wave here, the T wave is ventricular repolarization. Okay, so this is the point where the ventricles are starting the process and then completing it of recovering or relaxing. Okay, heart muscle is a little bit different than skeletal muscle in that it takes a lot longer to relax. Skeletal muscle, it's really important for you to be able to contract a muscle and then relax it immediately, because for fine motor skills, sometimes it's necessary to do a lot of tasks in a very short period of time, and that level of control is important. In the heart, it's a pump. It doesn't do a whole lot. It's not a jack of all trades kind of muscle. Its job is to rhythmically, for the entirety of your life, contract and then relax again. Contract and then relax again. It's really quite a boring muscle. Okay, that's all it does. It just contracts and relaxes. And part of that, just with the way the muscle is structured, it takes a lot longer to relax. Okay, so within this, that becomes relevant because you're going to see periods where it's finished contracting, but it hasn't relaxed yet, and that makes a difference to the filling stuff. All right, so we've covered the ECG. Okay, so we have our atrial contraction, ventricular contraction, ventricular repolarization, PQRS T waves. Okay, that's what that is. That's all that's happening in the ECG. All right. Now, if we were to take that and we take what's happening electrically with that ECG and we transpose it onto volumes of the left ventricle. Remember, once again, the left ventricle is the one that's actually pumping out to the body. All right. So that's kind of, if you were to focus on which of the two is left or right ventricle, which one is most studied, which most concerned about. In general, we're more concerned about the left ventricle of the heart. Simply put, the right ventricle doesn't have to do a whole lot of work. It's not very difficult to eject blood into the lungs because there's not a whole lot of pressure to work against. So it tends to be, of the two chambers, it's not as hypertrophied. The muscle walls aren't as strong because, once again, its job isn't as hard. The left ventricle has to push against your blood pressure, your diastolic blood pressure, the pressure that's on that valve going to the aorta. That's so it has to push against more pressure, and we'll go on and we'll see what more repercussions of all that. Anyway, that's why the only volume you're seeing here is that of the left ventricle. Okay, so if we look at this, let's start with a P wave. Okay. Oh no, actually, we'll start out with the beginning. We'll start here where we're just starting a whole sequence. Okay. So starting here, relaxation has just begun. Once the left ventricle relaxes, that is, the muscles are no longer contracted, they're able to kind of distend and become more elastic. Blood is just passively, okay, it's just passively filling. All right. So from here to here, this period of time, the valve here, if you look, is just kind of open. Blood's just kind of flowing in. All right. We call that the passive filling phase. Okay. Now, at the end of that, you have an active filling. Okay. Or sometimes it's called an atrial kick. So you see, volume goes up and then it kind of plateaus. Right here at the P wave, which is once again the atria contracting. When the atria contract, they squeeze. Think about like squeezing a toothpaste container. They contracts on that bolus of blood, whatever's left. It squeezes it, and you get just a little bit more volume into the left ventricle. Okay, so that hits. This is the maximum amount of blood you're going to have before contraction. Okay, another term for that is end diastolic volume. Okay, and then we're going to touch on that later. I bring it in now because it's something we're going to be referring to, and I want you to be, cognizant of what we're talking about. But think about it; it all makes sense, right? Diastole is relaxation, right? Relaxation phase. End of relaxation phase, end diastolic volume. Okay, so volume of left ventricle at the end of diastole. All right, so that's the end diastolic volume. So now we have contraction. The ventricle, which has been filling from this point, starts to contract. Okay. Now, as it's contracting, as I've said before, the difficulty that the left ventricle has is trying to overcome your blood pressure. Okay. If you were to think about it like this, if you had a door, take any door, all right, and if you have a person on one end of it, and you're trying to push that door open, the bigger the person is on the other side, the harder you have to push to overcome the amount of force that they're putting on that door. All right? Sounds simple enough. That's essentially what the left ventricle has to do. The difference is the door, in this case, is the valve, the one-way valve that goes from the aorta to the left ventricle, or rather the left ventricle to the aorta. And however much pressure you have in your arterial system, your blood pressure, however much pressure is sitting there, that ventricle has to overcome that pressure before the blood can leave the heart, right? Just as you have to overcome whatever, in this case, the person on the other side of the door, you have to overcome the person on the other side of the door before you can leave the room, right? Because that door is stopping you from leaving, all right? So, with that, you have this little phase right here called isovolumic contraction. Okay, and what that is as you know, the ventricle's now full of blood, and it's starting to contract, and all the muscle walls are all starting to contract, and as they're contracting, they're developing pressure within the system, right? Because if you have any liquid, as you start to make the container smaller and smaller, the pressure within that container builds, right? I mean, if you guys ever, popped some packing bubbles or anything like that, you have to press on it. The more you press on it, the pressure increases, and eventually, in that case, pressure overcomes the whatever structural integrity of the plastic is, and then it pops, right? In this case, as the left ventricle starts to develop pressure by contracting, it's going to have this period of isovolumic, so no change in volume, but it's still contracting. And once enough pressure has been developed, well then the pressure overcomes the pressure of your blood pressure, your diastolic blood pressure, and you have ejection. Okay, quite simply, same deal. If you overcome the pressure on that door of the person who's keeping you in the room, you can eject yourself. You can leave because you've opened the door. Same deal. Okay, so once that phase of systoles happen, once you've overcome the pressure against the aortic valve there, well then the blood can leave. Okay, and as the blood starts to leave, naturally, if the blood's leaving the ventricle, then its volume is decreasing. Okay, so that's your ejection phase. All right, and after it ejects, not all the blood, because you're never actually getting all the blood out of a ventricle or any of your chambers really. There will be a certain amount that stays, but once you eject a certain amount, then you have a period right here called isovolumic relaxation. Okay, and this is during the T wave up here. During the T wave, as that ventricle is trying to repolarize and relax, what you have here is there's no more blood to leave. Okay, the blood is all gone that's going to leave, but the walls of the ventricle haven't relaxed yet. So the volume isn't changing inside the ventricle. No more blood is coming in. So it's just kind of like stuck there for a second. Or not a whole second, but microsecond or a fraction of a second. All right. And then once it finishes its relaxation at the end of the T wave here, well then the muscles of the ventricle relax, and it can start filling again passively. Okay, and that's one cycle. Okay, relaxation, filling, atrial kick, fills more, contraction of the ventricle, develops pressure, valve to the aorta opens, pressure drops, or rather volume drops, and then you have relaxation, and once it relaxes, it can start to fill again. Okay, that is one cardiac cycle. Okay, so here we can look at the intercalated discs. All right, so an intercalated disc. Okay, coming back in 3, 2. Alright, looking at intercalated discs. This is how, as I showed you earlier, looking at that heart muscle, how as a signal of electricity goes from the SA to the AV to the bundle branches to the Purkinje fibers, all that, how the heart muscle is able to just spread the contraction or spread that impulse across its musculature, right? Now that's, as we know from neuromuscular physiology of skeletal muscle, that's not something that the skeletal muscle is capable of. And in skeletal muscle, every single muscle that contracts has to have a nerve going to it, right? And in that way, as we develop more coordination, it's really just a matter of your motor cortex and you developing the capacity to contract all the different neurons or move the different or activate the different neurons in the right sequence. Well, in the heart, it's a bit simpler. All you need to do is send a signal down the center of it, and the signal will spread out uniformly. And the thing that allows that to happen are these intercalated discs. Okay, so essentially what happens is in the case of this we have skeletal muscle. Okay, so skeletal muscle, there's still sarcomeres. Sarcomere structure is all about the same in a myocardium as it is in normal muscle cells. But you have these discs, and what they do is they just allow the action potential to just skip around. Okay, so these discs are all over um, the myocardium, and as you have any kind of a contraction go through it, it will uniformly spread. Okay, so there's advantages to that, and there's disadvantages. Okay, so now on to heart rate control. Um, so let's look at the things that dominate that. Okay, so as I said, um, your heart is, if you look at the actual heart itself, you have your SA node, your AV node, and then it comes down into the different fibers that kind of go down in different bundles. Okay, but upstream of that, you have sympathetic and you have parasympathetic input, just like in the muscle. Okay, only difference is if you have sympathetic input, then the sympathetic input to the heart tells it essentially to go, but in this sense it's increased rate of contraction. It's also increased contractile force, which we'll see in a bit. Okay, whereas the parasympathetic does the opposite, same deal, gas pedal, brake. That dynamic isn't different, but anyway, the sympathetic and parasympathetic drive, as they're often referred to, um, those come off of the spinal column, of course, and then up into the brain. Okay, so some other things that control heart rate. Right, there's this reflex called the Bainbridge reflex. Okay, the Bainbridge reflex refers to atrial stretching of the right atria. All right, so it's an interesting thing that happens in the heart when increased pressure is sensed in the right atria. It will immediately start increasing heart rate, breathing rate, also urinary output. Not super important for us in the exercise realm, but it is something that has happened. And take a second. I want you to think about that. Why would that be? So this is I haven't gone over this, of course, so it's not something I'm expecting you to know. But if you think about it, it does make sense. Why? When the pressure of the right atria, right, the right atria increases, why do we have an increase in heart rate and breathing rate? Remembering, of course, that the body is a feed-forward system. Okay. Well, okay. Here's your answer. When you start to exercise, you guys probably remember something called the muscle pump. All right, and that is when you contract your muscles, when you start to say run or lift a weight or something, your muscles will contract. Okay, and when they contract, they squeeze the veins that are around them, and when they squeeze the veins, it causes more blood to go back to the heart. More venous return is a term that we would use. Venous return. All right. So when you have an increase in venous return, that all comes up to the vena cava. Vena cava pours down into ding ding ding, right atria. Okay. So when you start having an impulse of blood go to the right atria, more blood going into a container means an increase in stretch and or pressure within that container. All right? So what your body does at that point is says, okay, I just had a bunch more blood hit my right atria. This probably means that I've started to work out, that I've started to increase my intensity or my workload. My metabolic systems are probably being more taxed, or they will be in the coming seconds and minutes, maybe an hour, I don't know. So the very first thing that causes your heart rate to start increasing, directly related to the exercise, is this Bainbridge reflex. Okay, so if you start getting an influx, heart rate will go up. All right. And as your heart rate starts to increase, it means your cardiac output, so your ability to move volume of blood through the body, that's going to go up as well. Because that's one of the elements is heart rate. So you're moving more blood faster, which means you're getting oxygen to the musculature faster. You're removing byproducts faster. CO2 is getting out of that blood faster. You're getting substrates to the muscle, right? You're getting maybe fats are circulating better, carbohydrates, all those are getting to the muscle, right? And the byproducts are getting pulled out, that lactic acid, hydrogen ions, all that stuff, okay? So that's the importance of this. So it kind of starts that logistics chain of moving stuff to the working muscle and then also pulling things away from the working muscle so that you can have support for the exercise. Okay, so it's very kind of cool. And then the other part, breathing faster, increased VE, minute ventilation. If you're breathing faster, well then you're oxygenating blood faster, but you're also, importantly, breathing out carbon dioxide faster, right? So it's all feed forward. That's the very first step in the chain, the Bainbridge reflex. All right. So the other thing, catecholamines, epinephrine is this term catecholamine. I don't think I've touched on it too much, but a catecholamine is a kind of a family name, a group name of hormones, endocrine hormones. Mostly when we say there's a catecholamine response, we're probably talking about epinephrine. Epinephrine is of course adrenaline. So that fight or flight hormone, we're going to talk about it a bit more when we get to the endocrine system particularly. But anyway, epinephrine kind of has its fingers in all of exercise phys. So here it is. Epinephrine stimulates or essentially causes a sympathetic response. Okay, so it has the same effects as the sympathetic nervous system, which are increasing heart rate, amongst other things. And then there's other drugs which mimic either the parasympathetic or the sympathetic neurotransmitters, and if they're mimicking that, then they're going to have the same effects. And as you can kind of see here at the bottom, parasympathetic and also sympathetic neurotransmitter blockers. So there's drugs that can block the input. In the case of, say, someone who's got heart problems, sometimes they take something called a beta blocker. A beta blocker blocks the input of epinephrine, so when you get an adrenaline rush, it doesn't increase the heart rate of that person, and that's protective of for their condition. All right, so let's talk about something that's exceptionally important as well. Okay, the Frank-Starling mechanism. Okay, and this is going to go into putting a few different systems together, but it's well within our grasp. All right. So the Frank-Starling mechanism. Frank-Starling mechanism speaks to, and in its most simplest term, it says the more blood that goes into the heart, the more blood you'll get out of the heart. And that's true on a couple levels. Okay. Intrinsically that makes sense. The more people who walk into a building, more likely you're going to have more people walk out of the building. Simple, cool. But there's a little bit different thing that happens here in the Frank-Starling mechanism. This mechanism speaks to essentially sarcomere lengths. Okay, if we remember back to that first unit, we had to talk of optimal sarcomere length. Okay, and if you remember back to that, the optimal length for a sarcomere was somewhere between 100% of resting length and 120%. It was somewhere in there. It had ended up going a little bit higher as it got to that 120%. All right, and if you were underneath that, it was lower, and if you're above that, it was also lower. So within the Frank-Starling mechanism, essentially what we're seeing is when more blood returns to the heart, what happens is that heart stretches a bit because it's getting more blood coming into it. So it's the walls are expanding a bit, and those walls are of course made of muscles, and that means they're made of sarcomeres. And as those sarcomeres are expanding out, and they're being pulled, they're actually being pulled into a more optimal orientation. And that, to a certain extent, speaks to, or it speaks highly of our adaptations to working at higher intensities. Okay, because what that means is that right now, as you're sitting here listening to me talk about this stuff, um, your heart is the muscles of your heart, the sarcomere of your heart, are actually sitting at less than optimal orientation. So you're getting ejection, you're getting a certain amount of contraction out of those sarcomeres. But if you were to start exercising, as more blood started to go into the heart, the sarcomeres would start being pulled into a more optimal orientation, which means the heart is actually contracting harder as you start to work out more. So as you start having more blood returning to the heart and that cardiac output starts to go up and you're working harder, your heart is actually starting to not only beat faster, but you're also getting um, more forceful contractions. So you're getting more blood out. And that blood out, is referred to as ejection fraction. Okay, so the ejection fraction is, if you take the volume of blood that's being ejected, okay, the amount of blood that's leaving the heart at the end of systole, and if you were to divide that by the total blood in the ventricle, then you have an ejection fraction. Coincidentally, this amount of blood that leaves the heart is also called stroke volume. Okay, stroke volume is the same thing as the amount of volume leaving the heart at each contraction. All right. So anyway, if you look at this, the Frank-Starling mechanism speaks to increased blood coming in, causing muscle walls of the heart to stretch, and as they stretch, they're pulling sarcomeres into a better orientation, which means when they contract more forcefully. Increased force means higher ejection fraction. And if you look here, an average ejection fraction at rest for most people is about 60%. Average while exercising is 85% or more. Okay, so you're getting efficiency. Not only is your heart beating faster, but with each pump, you're getting more blood out. Okay, so here's some things that influence preload. Okay, and let's talk about preload for a second. The term preload speaks to end diastolic volume. Okay, they're the same thing. If I were to say preload, and we already mentioned the term end diastolic volume, they're actually the same thing. All right, so some people call it preload, some people call it end diastolic volume. We're talking about the exact same thing. Okay, so preload is the amount of blood that comes back to the heart before each ventricular contraction. All right, so things that affect the amount of blood coming back to the heart prior to each systole phase. Okay, so first off, venous return, the volume of blood coming back to the heart, and that's affected by posture greatly. All right, so posture, and that's dealing with gravity mostly. All right, and so think about it. If I'm standing upright, if we look at this instance, this little stick figure right here, if I'm standing upright and I have the earth underneath me, presumably, gravity is pulling me down. Gravity is also acting upon all the blood inside of your veins, your arteries, your body in general. Okay, so naturally, the blood wants to pool in your legs. That's what it wants to do. If given the chance, that's what it'll do. The blood just wants to go. It wants to go to the furthest point down as possible, because that's what gravity's telling it to do. Gravity is pulling on that blood all the time. All right. So factors affecting preload. If you have gravity pulling blood down, it means that you're not returning as much for each contraction. All right. So what you'll tend to see here, and we'll cover this later, but cardiac output, or the amount of blood that's coming out of the heart per minute, is equal to heart rate times stroke volume. Okay, and as we just saw from the last slide, stroke volume has everything to do with that Frank-Starling mechanism, and it is the amount of blood leaving the heart each time. So this is the frequency right here, and this is the volume per pump. Okay, so if we have heart rate, number of beats per minute, and then you have how much volume is leaving per pump, well then we can get a number of liters per minute, which is cardiac output. Alright, anyway. So, going back to this a little bit. Okay. If gravity's pulling blood down and I'm having a hard time getting it back up to my heart, what's going to happen is stroke volume will be lower, and if I want to maintain an equal cardiac output, it means that heart rate needs to increase. That's just simple mathematics, right? If I want to have 4, I can either have 2 times 2, or if this decreases to 1, well then I have to have 4 here, right? Because that's to equal 4, I need to make this equation balance. Okay. So that's about the entirety of mathematics we're going to cover in this unit. Um, anyway, so the more upright you are, the harder it is to get blood back to the heart. And you see this in exercise equipment and also the types of exercises that you prescribe to various people based upon their condition, right? Have you guys ever seen a recumbent bike? A recumbent bike in a gym. Recumbent bikes are the ones that have the big seat backs, and they're usually pretty padded, and they're so you sit upright, but the pedals are out in front of the person instead of being underneath them. Sometimes you'll see people biking in the streets. They've got these bikes that they almost are laying down in. Those are called recumbent exercise bikes, and the reason for that is that the more horizontal you are, the easier it is to get blood back to the heart, right? Because gravity is pulling equally down on you during all points, so it doesn't actually affect stroke volume quite as much. So what you see in these people, in these instances, is in order to maintain an equal cardiac output, you can have a lower heart rate because stroke volume is higher. Okay, that's why, and you can test this. At any point, as you're sitting upright, your heart rate will not be as high, not be as low as if you laid down. Okay. So, go on, get a heart rate monitor, check it out. But posture, simply the way gravity is interacting with your body, affects how much blood is coming back to your heart prior to each pump. Okay, other things relating to preload. One of which, major one, is venous tone. All right, so venous tone refers to how much contraction there are, or there is, within your veins. Okay, so your veins, as you may or may not be familiar with, veins are not nearly as muscular as arteries. They do have some smooth muscle within them. And anyway, during rest, the majority of your blood is actually sitting in your veins. Okay, 60% here, big piece of that pie of your blood is sitting in your veins. Okay, so often they're referred to just being kind of like flaccid tubes full of blood, but during exercise, specifically epinephrine will do this. Epinephrine will cause contraction in these veins, and what that contraction does is if you lower the volume of the veins, then it's easier for blood to work its way back up because it doesn't it's got less say volume to fill before it's coming back to the heart. So through exercise, during exercise, veins tend to contract just a little bit, and that makes a big difference for the return of blood back to the heart. Let's get rid of this. And the muscle pump, I've kind of already gone through this, but let's get a little graphic on it. Veins have one-way valves in them. Okay, so this is to prevent backflow, because like I say, gravity, if given the chance, will just pull all of your fluids down to your ankles. In some people, in some populations, this is very evident. And if you have valvular problems in your veins, you'll have this backflow, and that causes pooling of blood at the ankles and feet and that sort of thing. But anyway, in normal, healthy, functioning veins, they're one-way valves. So as your muscle contracts, it squirts blood up, and then once it relaxes, the blood can't go back down, right? Because of this valve here. I'll change color. this valve. Okay. And anyway, as you contract your muscles, moving up, the blood will just get squirted from one section to the other. Eventually, it'll make its way all the way back up to the vena cava, go back to the heart, and it can start its cycle again. Okay, another thing it's kind of honestly about the same thing, the intrathoracic pressure. Right, so the amount of pressure within your thoracic cavity, pretty much having to do with your breathing, causes pressure to be put on your veins, your vena cava as well, your vein system, right? So every time you breathe, swell up your lungs start increasing pressure within your thoracic cavity, and the vena cava is within that. It gets squeezed, and that will cause blood to come back to the heart. Other factors, of course, blood volume. Okay, for whatever reason, if you have a lower volume of blood, well, then you're going to have less blood returning back to the heart. You have less to work with. Okay, so that would also affect preload. Heart ventricular volume. In certain conditions, there will be a reduction in the amount of volume that the ventricles can take, so their stroke volume decreases. As we saw with that cardiac output equation, if the stroke volume is going down, then heart rate has to go up. Okay. Atrial priming, if the aorta aren't working correctly, then they don't force as much blood down into the ventricle. And if less blood is being squirted down from the aorta, well, then you're getting less preload, right? It's not having as much in the ventricle. All right, so all of these things together they give us an end diastolic volume, okay, or preload. So end diastolic volume, once again, same thing as preload. If you take all those things together, intrathoracic pressure, venous tone, muscle pumps, volume, positioning, atrial kick, all that stuff leads to a certain amount of blood being pumped down into that ventricle. And the more blood you can get into the ventricle, the more it's going to stretch. And the greater the stretch, the more forceful the contraction. Remembering the Frank-Starling mechanism. And if we look at this is ventricular performance, this graph right here. It's very simplistic, but ventricular performance increases as ventricular end diastolic volume increases as well. Ventricular performance can be simply rated as stroke volume, right? Because that's its job. Its job is to get blood out of the heart. So if the stroke volume is low, if its ejection fraction is low, it's having low performance. If every pump that ventricle is getting a lot of blood out, then it's performing well. It has high productivity. So there you go. So the next thing we want to talk about is distensibility. All right, the heart. As we already talked about heart rate a little bit, we talked about stroke volume going out, we've talked about Frank-Starling mechanism, and part of that Frank-Starling mechanism is the stretch, the capacity of the heart to be stretched. Okay, we can call that distensibility. Right. So there's various things that affect that. One being resting sarcomere length. Okay, the more tension you have within the sarcomeres, which sometimes happens with certain conditions, you'll have a stiffness, an inability for the heart to distend or become filled. All right. So if you have less stretching capacity of those sarcomeres, then you're going to have less distensibility, less ability for it to be filled. All right. Same thing kind of goes with relaxation state. If the cross bridges are kind of associated even a little bit during rest, if they have too much, say, calcium floating around, then the heart will be more stiff and it'll have a harder time being filled or stretching. Connective tissue is another thing. Sometimes through aging, obesity, in some instances we've seen fat deposits develop within the myocardial or pericardial sac. That can affect the ability to stretch as well. But connective tissue, sometimes, say with a heart attack or damage to the heart, you can have connective tissue will cause stiffness as well. Scar tissue goes along with that. Um, if you're having, if you have areas that are especially coming from a myocardial infarction, a heart attack. In a heart attack, if it doesn't get resolved within the first like 15 minutes or so, that bit of heart dies. Okay, that bit of myocardium that was affected by the heart attack, it dies and it doesn't recover. It just becomes dead cells. Um, so the example put forth in this bit of text here is that if you took a balloon and put a piece of tape on it, and then try to blow it up, that's kind of what happens um, when someone has a heart attack. Is that piece of tape would be the scar tissue. So as everything else is trying to stretch, the uniformness of that ventricle filling becomes impaired because of that scar tissue. All right. You can also have masses around the pericardial sac. That happens in some instances. I already talked about the obesity. Thoracic room is also sometimes problematic, usually in more acute, more emergency situations. But that's one thing as well. If there's pressure, say within the thoracic cavity, if there's just not enough space for the heart to fill fully, then you'll have reductions in preload. All right, and then the last bit here deals with the contractility. Okay, so contractility, as the name would imply, has to do with how forcefully the heart, or the left ventricle specifically, can contract. Okay, and if you look at this kind of cross section from the top of what the heart looks like, you can see very clearly this is the right ventricle and this is the left ventricle. The left ventricle, this is the actual filling space here. Right ventricle is all this. Okay. The left ventricle has really thick muscle walls because it has to overcome more pressure. Right ventricle only has to eject to the lungs, and there's very little pressure between your heart and the lungs. So it's not a whole lot that has to work against, so it doesn't have to be quite as muscular. Anyway, things affecting contractility include, but are not limited to, muscle mass. So the more thick the walls are, the more muscle you have, the harder the heart will contract. Calcium. Okay, this is typically dealing with drugs that will affect calcium. But anyway, the more calcium, the more force, as we know from the cross-bridge cycle. Right? Works roughly the same, except the SR is not involved. It just happens to be that the calcium's in the fluid around the heart. Okay. We have sympathetic input, parasympathetic input. So if you have sympathetic input, it's going to stimulate more calcium going in. You're going to have a greater response, greater force, more forceful contraction. Parasympathetic is just the opposite, so less forceful. Catecholamines, once again, kind of stimulate the same thing as a sympathetic. Drugs, you can have calcium channel blockers, which would reduce the amount of calcium available, which would reduce contractility. You have others that will increase the amount of calcium that's released and increase force of contraction. And then the buildup of metabolic end products will also affect the contractility of the heart. So things like hydrogens and lactic acid and that sort of thing. So, last little bit I want to talk about is something called afterload. Afterload is a term that's sometimes used, but what you probably know this as is diastolic blood pressure. Okay. So afterload, or diastolic blood pressure, is the amount of pressure on the systemic side of the semilunar valve. That's the valve that goes out to the aorta. Okay. So as I've been talking about, as I was talking earlier about ejection fraction and trying to get blood out of the left ventricle, and how it's so important of different filling phases and all that stuff. And I was saying how the left ventricle is more muscular because it has to work against more pressure. That's afterload. The greater the afterload, the greater the force that the ventricle has to develop to get the blood out. And if it has to contract harder for a long period of time, it also means that it's probably going to hypertrophy and get bigger. In most every muscle in the body, we would be happy about that. In the heart, we are not. So that's a problem. I get into that later in other classes. I go much deeper into that. But for this, just know that hypertrophy of the heart is not a good thing. Anyway, so things that affect diastolic blood pressure or resting blood pressure or resting phase of the heart cycle blood pressure. Sympathetic and parasympathetic input. So if you have more sympathetic, you have a higher diastolic blood pressure. Same, parasympathetic will indirectly lower your diastolic blood pressure. Catecholamines, C number one there. It's adrenaline causes sympathetic response, which would increase diastolic. There are certain drugs, anatomical impedances. Okay, so the big one that we usually talk about there is like clogging of the arteries, atherosclerosis. If you have masses that have kind of formed within the arterial system, then there's an amount of blood being put into a container, but the container is essentially smaller, which means the pressure is higher. Okay, and then intrathoracic pressure is another one that you have to work against, and that one is mostly like the best way I could give that example is like lifting weights. As you're lifting weights, you're probably, if you're lifting heavy, you're probably doing a Valsalva maneuver. You're holding your breath, which is causing more pressure within your thoracic cavity. Also, contraction of muscles are putting pressure on arteries as well, which is lowering their overall volume. And all that in summation, same thing as atherosclerosis, momentarily will cause an increase in blood pressure.